Good morning, everybody attending this webinar. Good afternoon, good evening to some of you, and welcome to one more installment of Knowledge for Change webinar series, which is run by the World Hepatitis Alliance. Now, for those who do not know the World Hepatitis Alliance, we are an NGO. We are the only global organization advocating for the millions of people living with our hepatitis. And we're here today to discuss the role of generics within the hepatitis C access landscape. My name is Raquel. I'm the CEO, and here with me we have great experts to lead those discussions. And I think the best way to start really is by perhaps introducing our panelists. So if I could just ask perhaps Erika, would you like to tell us a little bit about you and where you're connecting from today?
Yes, hello. Hello, everybody. I'm Erika Dueñas. I work with the Medicines Patent Pool, and I'm connecting from Geneva.
Thank you, Erika. Giten?
Good evening. My name is Giten, and I work with Rhodesia AMFA, the Foundation for AIDS Research, and I'm based in Bangkok, but I'm currently speaking from India right now.
Good evening, then, Giten, to you, and Dr. Andrew Hill.
Hi, my name is Andrew Hill. I'm from the Department of Pharmacology at the University of Liverpool in the United Kingdom.
Thank you so much. And just before we start, perhaps a reminder to our participants today, and if we can go to the next slide, please. Just a reminder that you can send us questions by using your functionality here in the control panel, and we'll be trying to do our best to address them during the webinar. So, okay, so why don't I just start very briefly by setting the scene to what we're going to be discussing today. So, as some of you know, this year was a very special year for our hepatitis. We had 194 governments signing up and adopting this global elimination strategy back in May. And essentially what it means is that they set this deadline, 2030, to eliminate viral hepatitis. And what I wanted to pick out of this document, and by the way, we're going to be making those documents and links to what we're going to be talking about here available later. But what I wanted to pick out from that is that in this document we have a very ambitious target regarding treatment, which is 80% of patients with hepatitis C being treated. And just to put that figure in perspective to all of you, right now the current situation is that we have less than 1% accessing treatment. So when talking about hepatitis C, which is killing 700,000 people every year, out of 80 million people out there, less than 1% is receiving treatment. Now we know that there's a lot to be discussed here. We have the high cost of drugs. We have a lot of barriers. But again, in this webinar, we're going to be talking specifically about generics. And we know that generics has been the most effective way to drive down those prices. So why don't I just give the floor, and in this case, actually the screen, to my colleague Erika to just discuss a little bit more around the role of the Medicines Patent Pool and what you've been doing in the generic scene. Erika, if you can talk a little bit about the MPP for us.
Yes. First of all, thank you very much for inviting the Medicines Patent Pool to this important webinar. And I would like to share today some information with the participants about how some of the new HCV medicines are becoming available as generics in many countries, in certain developing countries, and how we can access to these drugs. So if we go to the first slide, to the next one. This is the list of several new medicines and combinations for hepatitis C. As you can see in the first column, there is the name of the medicine or the combination, then the second column, the brand name, and then the date of approvals of these products by the US Food and Drug Administration. As you can see, they are very recent. For example, the Daclatasvir was approved in July 2015. or very recently sofosbuvir in combination with velpatasvir in June 2016. If you go to the next slide, please, you can see also that some of these generic versions are becoming available in a number of developing countries. And that is why I would like to tell you that it's very important to understand where these medicines are patented, in which countries, and also where there are licenses for these drugs. Because I will share with you these 3 potential mechanisms for access to generics in a country. The first possibility is if the manufacturers make the product in a country where it is not patented, and for sale in a country where it is not patented as well. So then I'll show in another slide why it's also important to check in some countries if there is data protection exclusivity in some countries. Then the second possibility is if manufacturers have obtained a voluntary license from the patent holder. And this can be, it can be in 2 ways. Either by a bilateral license agreement, which is a license between the originator and the manufacturer, or a medicines patent pool license, which is through the medicines patent pool. I think we explained that in the previous webinar, right? That it is available, as you said. And then the third possibility is if a country were to make use of a TRIPS flexibility or public health safeguard. And for example, the compulsory license, right? So if you go to the next slide, you can see the list of the existing voluntary licenses for hepatitis C. It is important to know this information about the licenses because the license enables multiple manufacturers to make the generic version of the medicine, even if there is a patent in that country. So that is why if you see in the first column, you can find the license for daclatasvir, for example. And if you see the license includes at least 112 countries. And it is a license negotiated by the medicines patent pool, through the medicines patent pool. And it is important to mention that if it is the case, it includes very pro-public health terms and conditions. And the second license is on sofosbuvir and the combinations of sofosbuvir with ledipasvir and with velpatasvir in that case. And it's a license for 101 countries. And it's a bilateral license, a license from between the originator and some generic companies. As you can see, there are no other licenses so far. So next slide, please. Then I'll quickly share with you our new tool, which is MedSpal. It's a medicines patent pool, patent and licenses database. It is a very friendly tool that can be used by anybody. It's in our website. And you can do some search by key product or by countries. And or by patent number, for example, and you will find interesting information. I'll share with you an example, which is easy to see. Next slide, please. In this example, you can see that we find in those circles in green, we try to find information for sofosbuvir 400 milligrams, and we decided to find it in Malaysia. What is happening in Malaysia with this product? So you can see that you have information about the product in the country, and also in the patent status column, you can see that there are 2 patents granted for sofosbuvir and 3 filed. As you may know, there can be many patents for one single product, right? In this case, there are different patents for the compound, which is the main patent, or other secondary patents that are some improvements, the prodrug, or for the processes, or for the compositions. and probably more, but those are the ones we identify as the most important blocking patents. So if you can see in the last column, also the expiry date of each patent. It's interesting. You can see that sulfosbuvir compound expires in 2024, but the sulfosbuvir composition expires in 2032. So there are differences. And then another important information that you can find as well, if the country has data exclusivity protection, you can see in the red circle in your left, you can see the expiration date of data exclusivity protection in 2018. So that's also very relevant information. In this case, this expires before the patent. But in some countries, you can also find the opposite, that it's possible to have the patent expired, but you still have data exclusivity protection. So next example, please, next slide. You see here we try to find information from India and South Africa on daclatasvir 60 milligrams. And it's very interesting what we found there, if you can see in the patent status column, that there are 2 filed patents in India and 2 granted patents in South Africa. As you can see in the first red circle, you can find also information about oppositions in the countries where the legislation allows oppositions. In India, the first patent has been opposed, so we still don't know what is going to happen. In South Africa, you can see also the information on the patents granted, and the information in this orange circle, you can see the information on the patent number, the patent application. If you click in that button, you can see in my next slide, please, you can find the details, the specificities of the patent, the details of each patent. If you go back again, please, to the other slide, if you see as well a very important information on your left in that blue circle, you can find information about the medicines patent pool license on daclatasvir. That means that even if South Africa granted the 2 patents, the generics can be available for South Africa because there is a patent license signed by the medicines patent pool. So this is a very relevant information, and if you click in that blue thing, you can go to my next slide. You can see the details on the license. This is a license card we have for each of our licenses, where you can find relevant information about the product, the countries that are included in that license that can benefit from this license. And also important to mention that not only this license card is available, but if you go to our website, you can also find relevant information and the entire text of the license agreement, because we, as a medicines patent pool, promote transparency of these license agreements, right? So you can find the entire text of the license and the sub-licenses. And finally, very important, the licensees are also available there. That means that in this green circle at the end, you can see Aurobindo, Cadila, Cipla, Emcure, Hetero, many generic producers that are already developing daclatasvir in that case. So we are available to answer your questions or to be contacted in the future as well. Thank you.
Oh, thank you, Erika. That's been really, really great. And this tool has been recently launched, right?
Yes, we used to have another patent database that was very well used by the public and very appreciated. That is why now we improved that database, and we included also information on licenses, on data exclusivity protection for each country, and we're trying to improve the tool.
This is great and very simple to use too. And I already have a question, which is around accessibility of the medicine to a patient. So for instance, someone looking at the database and checking for availability of drugs, of generics, or the license agreement in their country. So for instance, let's just take Angola as an example, and there is a license. What does it actually mean to the patient on the ground there? in terms of timelines? Does it mean that they can access these drugs? Does it mean that they have to knock on the government door and ask for the drugs? Could you explain a little bit more, please?
Yes. Yeah, thank you for your question. Of course, it is a very, as you said, it is a very friendly tool. So it is available for patients, for procurement agencies, for anybody. So, and for the patients, it's very important because they can see the information on patents and if the patents are granted or not granted in their country, or if there is a license that can allow the generic products in his country. So then they can use this information to work together with their government or to try to promote the country to benefit themselves and their countries to benefit from these agreements, for example, if there is a license agreement. So it is very important for the patients to have this tool and to try to get these drugs.
Right, so we can perfect. So we can use it as an advocacy tool. No, that's very good, and I'm glad that that MPP launched the information with the Hep C drugs there as well. And I think now that we're talking about patients is a great leeway to Giten's presentation. We're going to be talking about the real life experience and how patients are accessing those generics for their own individual use. Giten.
Thank you, Raquel. I'll be talking, and good afternoon to everybody. I'll be talking about real life, how people are actually accessing the direct-acting antivirals, which Erika talked about for individual purposes. Just to give you some sort of an outline, I'll be preparing you with information around the direct-acting antivirals. I'll be talking specifically about the licensed DAAs because which are coming out of India. I'll be talking also about price reductions in terms of the generic hepatitis C medications and where we are right now. I'll talk a little bit about how it is being accessed more broadly in countries around the world, whether or not it is registered or formally approved by their FDAs. And then I'll come to the most relevant point of my talk today, which will be around the individual import, which sometimes is also called as named patient import, and how it's being done. And I'll give some examples of specific countries as to how it's being done, and I'll leave you with some of the conclusions. So we have the direct-acting antivirals. We know that we have had Sovaldi, which started as the first medication of the second generation direct-acting antivirals. We have had the sofosbuvir and ledipasvir co-formulation, which is named as Harvoni. And then we have had after that Daglenza or daclatasvir, which are the originated products that have come out as the first second generation direct-acting antivirals. Then after that, we have had the generic sofosbuvir, which are coming out of India. There are others which are coming out from other countries, but as I said, I'll be talking specifically about the Indian ones. We also have had the generic sofosbuvir and the ledipasvir co-formulated tablets, and we also have now the generic daclatasvir. The generic sofosbuvir, we have around 15 companies which are marketing, 15 or 16 approximately, marketing the generic sofosbuvir out of India. We have around 10 or 11 which are marketing the ledipasvir and sofosbuvir co-formulated tablets, and also another 10 or 11 which is marketing the generic daclatasvir. So that's the range. So if people have been receiving, you would have been receiving some different kind of brand names from different companies coming out of India. Now, going to the next point about the pricing as to where we are right now. In late 2014 came the first generic sofosbuvir at the end of 2014, and then we started tracking the price in the beginning of around May 2015, and it had a list price of approximately $330 US a bottle. Right now, if you follow the blue line, and if you follow right at the end of August 2016, we can get a bottle of generic sofosbuvir at approximately $83 a bottle. At the end of 2015, exactly around a year later, came the sofosbuvir and lenacapavir co-formulated tablets, and also daplatosvir. So if you follow the red line, against a list price of $384 approximately, you can get right now a bottle of soft and lenacapavir at approximately $143. You follow the purple line, which is the daplatosvir generic 1, against a list price of $92. You can get approximately at $38 a bottle, which is a month or a 4-week supply. So considerably, the price has been dropping, and as we speak, probably it's still dropping. So we're looking at approximately soft $249 for a 12 weeks therapy, daplatosvir for $114 for a 12 weeks therapy, and soft and lead combination approximately $429. So soft and that would be approximately $363 for a 12 weeks therapy, and soft lead $429 as I said. In India, there are some specific state government programs which have started treating people in their own respective state health programs, and they're procuring approximately around $270 to $280 for the government procurement pricing. So that's where we are, and the slide says about our individual purchases as we can get in India right now. What I mentioned about 280 is state-specific, not a national program, but a state-specific program in India where treatment is being provided to the citizens. How are this? We have this medication, we have the pricing across the world. How is it being broadly accessed? We have different ways of getting this. Now, the first way is at the hospital level. There are certain countries, like say for example in our region in Asia, Indonesia or Vietnam or Myanmar, which allows import of medications prior to a formal FDA approval. So they call it as special import quota or special import license or special assistance scheme. Each country has its own nomenclature of how this import is being done. But the FDA allows import of these medications prior to the formal registration approval, and that's how a lot of patients in Indonesia or in Vietnam or in Myanmar are getting medications which are still not approved. Say, for example, soft and lead co-formulated tablets. At the patient level, we have the named patient import, which sometimes companies call as compassionate use, or sometimes the FDAs or the regulatory authorities of the country actually allows import for personal use. We also have buyers clubs, which many of you must have come across or have heard about. And also, if one goes to India, they can get it from large pharmacies, and they can get it in larger pharmacies because the medicines are higher, of a higher cost, so that smaller pharmacies cannot stock it to the extent that you would want. So you can go to large pharmacies in India and you can purchase medication. So let's go to the most relevant one. How can one get? How is it being done at the patient level? So if we go to the first country which started is Australia. And the Therapeutic Goods Administration in Australia actually allows import for personal use. So prior to the initiation of the treatment program by the Australian government, which is a very, very welcome move, patients there have been actually importing 3 months doses with a doctor's prescription by courier. This is totally legal, and it's allowed by the Australian drug regulators. And a lot of patients have now been cured by using the Indian generics or other generics from elsewhere by using this route. The second one, for example, and I assume that there are listeners or attendees, participants in this webinar from the United Kingdom. And MHRA allows import of 3 months medication by courier again. And there is no need for a doctor's prescription in the United Kingdom. All we need is the person's shipping address and the age, and that's all that's needed. It's up to the patient to check the quality and the source of the medication and make sure that they're being monitored by a physician. You go to Hungary, and that's where again the FDA allows import for 3 months by courier again with the doctor's prescription. It has to be a Hungarian doctor's prescription. So patients from there actually gets his prescription, and then we can send it across. The only difference is in Hungary, patients have to pay a value-added tax of approximately 27% when the medicine actually arrives in Hungary. So this is a difference which we see in the case of Australia, different from Australia or from United Kingdom. But in Hungary, people can actually receive it. When we go to the next one, which is in North America, which is Canada, the FDA allows hand carrying of medication for a maximum of 3 months, and it cannot be couriered. So I'm talking about the legal route. So if you are planning to get shipments to Canada, you cannot get it couriered. But if you want to go somewhere else, to India or to Egypt or somewhere, and then get these medications in your bag and then go back to Canada, that's allowed by the FDA and the customs. Another Eastern European country, Romania, it allows a personal use for a maximum of 3 months. And it can be couriered to the person along with the doctor's prescription. So I'm just citing some examples so that it gives some sort of an idea to our listeners that it's legal in many countries, though the legalities and the tax system that's being used could be different. In conclusion,
can I just ask you a quick question, if I may? For people that are listening that are interested and they're outside of the countries that you listed, what's the best way? Is there a place where they can check what it's required, if they are allowed to import the drugs and what it's needed?
Yeah. So what they can one of the best ways of doing it, which I would suggest, is to contact their local HIV patient groups or harm reduction groups, which have been working on promoting access to HIV medications or other medications that has been ongoing for quite some time prior to the hepatitis C medication. They can also contact hepatitis C patient groups that are in those countries, and we should pass on that information and check with the legalities of importing and equip the people, the hepatitis C patient groups, to be equipped with the information as to how these medications could be imported, and patients which are not directly in touch with them could be helped by passing on and sharing their information through their websites or with their social media channels. So that can be done. So contacting HIV patient groups, hepatitis C patient groups, or harm reduction groups are a good way of making sure that they get the right information and they understand the legalities of how this can be done, and also the trusted sources as to make sure that they're getting the quality medications. So in conclusion, yeah, welcome. So in conclusion, what I would like to say is cure is accessible, but it's coming in small volume. And what we need to do is to allow larger public programs to be available, like how the Australians have done. We need this to be in place, because the small volumes and individual imports are not going to be able to eliminate viral hepatitis by 2030. Named patient import is legal in many countries, including in Europe. Local taxes could be different. So I would request hepatitis C patient groups or harm reduction groups or HIV patient groups to check as to what are the legalities and put it out in their social media and in their websites as to what are the tax and how it can be done, so that patients who are following them can actually need it. There is also a need to quality control, to check the quality control, as well as of the treatment implementation. A physician monitoring. These drugs don't have really high side effects, unlike the Peck interferon era, but it's always advisable to have some sort of a physician monitoring, because you might have certain side effects, and it might not necessarily be because of the treatment, but it's always good to have a physician monitoring when you're having some sort of a treatment. Please be cautious about the source of the medication to avoid any sort of spurious or counterfeit medication. It's advisable to be, I'm not saying that people have got fake medications or so, but we have seen WHO advisories on fake medications that were coming out. So it's always good to know the source of the medication that you're getting, and you're getting the actual genuine product rather than others. So it's in short, hepatitis C is curable. The medications are there. It's becoming a lot more affordable, but the prices need to actually drop down. If we are to have larger public programs to be in place, if we are to eliminate viral hepatitis C, we need these public programs to be in place, and not just a small volume import, which are going to treat individuals. And of course, please feel free to ask any questions, and I'll be happy to answer those. Thank you.
Thank you so much, Giten. Nicely put. Very strong message at the end there. I just wanted to make a very quick comment around the counterfeit. So we are going to try to put with the recording of this webinar, the announcement about that Giten mentioned on WHO, with the pictures of these medicines that were fake. So you're aware of that as well. But as Giten mentioned, it was always good to contact your patient group or groups that are experienced to obtain more information before you purchase those drugs. Thank you, Giten. So what I think I'll do, I'll just move to Dr. Andrew Hill to perhaps expand a little bit more on the buyers club, but also give us some very important data on the effectiveness of these generics. I mean, are they as good as the original drugs? And what else can be said about that? So, Dr. Andrew.
Okay, thanks very much. If you go on to the next slide. Okay, so my research team has been looking at how much drugs for hepatitis C and other diseases cost to make, and also when people take these drugs, when they forward them through buyers clubs or the internet, how well do they work? Do we have any evidence that they're good quality or bad quality? So on this simple summary slide, you can see the price of various drugs for hepatitis C in the United States, the current lowest prices as of July of this year in India. I think Giten has even lower prices now. It's amazing how quickly this is changing. And what we call the target price, this is what the drugs could cost in the future based on the cost of the raw ingredients being exported from India. So you can see, for example, sofosbuvir for a 12-week course costs approximately $50,000 US in the United States. It's available for around $300 in India for individual people. Should be available for much lower prices to treat large numbers of people. And then the target price is even lower. It's about $60 US. Declatovir is even cheaper as a target price, about $14, but still costs $50,000 US in the US. Sofosbuvir, lenacapavir, sofosbuvir, velpatasvir, they all follow the same pattern. What we're saying is fundamentally these drugs are extremely cheap to make, and it would cost approximately $10 billion US to treat everybody with hepatitis C worldwide. And actually that's not a lot of money if you think about the potential benefits of curing over 100 million people with this disease that kills 700,000 people a year. Next slide. So if you look in a bit more detail about costs of one drug, for example, sofosbuvir by country, you can see even within Europe and looking at Brazil, Australia, there's a huge range of prices that have been asked for by the pharmaceutical companies. So if you look at Germany, that's the most expensive country in Europe, followed by France, paying between 42 and 50,000 euros for a 12-week course of sofosbuvir, whereas Spain's paying 13,000, Brazil 6,000, Australia 3,500, India 288, and the target price. This is all in euros, by the way, 55. Now, if we go on to the next slide, we can see possibly why this is. Australia has managed to agree what's called an all-you-can-treat contract for hepatitis C. And they promised to pay pharmaceutical companies $1 billion Australian dollars, $200 million each year for 5 years. And in exchange, they are allowed to treat as many people as they like with hepatitis C. So this is approximately 138 million euros for unlimited treatment numbers. Now, they are on course to treat 40,000 people with hepatitis C in this year, 2016. That's 1 in 5 people with hepatitis C in Australia. And it means that their unit cost for a 12-week course of treatment is less than 3,500 euros per person. Now, if this price is acceptable in Australia, we should have access to these drugs at the same prices across Europe and other countries to make sure that we can achieve elimination of hepatitis C across the region. You look at the current prices being charged, and it would just be impossible. It would destroy health budgets if we had to treat everybody at the current prices. The levels like Germany and France with 45 or 50,000 euros per person per treatment. Next slide. So, what do you do? Well, how do you try and achieve elimination of FC? The first thing to do is to try and get to these low prices. I think if treatment costs in the region of 4,000 euros or less per person, a lot of parts of Europe, North America, Canada, Australia, a lot of the high-income countries could afford it. We need to make sure that the voluntary license agreements are put in place and actually followed through so people really can access drugs at those prices in the low and middle-income countries. But that's not happening at the moment. There are many countries where the cost of treatment is out of reach, and doctors are having to tell the patients, I cannot treat you because we don't have the budget. The drug is not reimbursed. Perhaps if somebody doesn't have cirrhosis or they've got the wrong genotype or they need too long a course of treatment. In cases like that, we're resorting to bias clubs or access programs. And there are many companies that make these drugs in India, Bangladesh, China, Egypt, and they're willing to export generic treatments either for HIV or DAAs for hepatitis into Europe and North America. Remember, some of these companies already have approval for their production, either from the US Food and Drug Administration for the HIV drugs, also from the World Health Organization. There was an announcement, I think last week, that 2 generic companies will have authorization from the Global Fund for use of their hepatitis C treatments in low and middle income countries. So what I'm saying is these companies are producing drugs to a high standard. If you wanted to buy generic treatment to prevent HIV or DAAs to treat hepatitis C, they can actually be bought online very quickly, only 10 minutes. And there's a variety of websites that put down here where people could potentially buy them. Next slide. So my research team has been looking at how this works for individuals, and there are links on these slides to news programs that we've worked on with the BBC, with Channel 4 News, following individual people as they get treated through these bias clubs with these generic drugs and how they get cured. So you could look on those links if you wanted to see what the individual experience is like. Next slide. I think Giten covered this earlier, but just to reinforce that the original TRIPS legislation does allow this flexibility that individuals are allowed to bring drugs into their own country for their personal use. And most countries allow some form of personal importation of medication. And at the moment, medicines are being sent from India, China, Egypt, and Bangladesh to countries all over the world to cure people with hepatitis C. I'll just show you the results now from some research we've been doing on the next slide. We're looking at various different countries and different programs and how they're working. So this is the Fix Hep C Bias Club. You can see the website in the top right-hand corner if you ever wanted to access treatment. You can use this Bias Club. Sorry, their cure rate is just under 90% at the moment. It's a little lower than some of the other buyers clubs because they've been treating some of the most difficult patients in Australia who had cirrhosis, who had genotype 3, and it was a very tough population to treat. But even so, 89% is looking good, and they as you can see from this graph, with world maps of where people have been treated, the Fix Hep C Buyers Club has a reach all over the world. We've treated people in Africa, Europe, Australia, North and South America, Asia, etc. So several thousand people have been treated through the Fix Hep C Buyers Club. Next slide. Okay, and so this is Greg Jeffries with his Hepatitis C Treatment Without Borders organization. Greg Jeffries actually had hepatitis C himself and got cured through taking generics from India. So we have personal experience of what this is like. This is an initial survey we've done looking at who's been treated where, and you can see again, just like James Freeman, a reach all over the world and cure rates already in the high 90%. Next slide. Some of this information was presented at the HIV conference in Glasgow last week. You can see here the Southeast Asia Buyers Club. This is Giten's program. And again, 92% cure rate with people treated in various parts of Southeast Asia. Next slide. And then finally, the ITPC, which is the International Treatment Preparedness Coalition in Russia, have treated again I think about 2,000 people across Russia, and the numbers are increasing very quickly. They have their own Facebook page, their own supply mechanism. The treatment comes in sofosbuvir declatosphere for 12-week supply is currently $490 US. Sofosbuvir velpatasvir is coming in from Bangladesh for $900 US for 12 weeks. They have access to all the most recent drugs produced from generic companies, and again, their cure rate very good, 98%. Having said that, it's a younger population with a lot of genotype 1 as opposed to 3, which is slightly easier to treat. Next slide. So we can see across these buyers clubs that it is possible to treat large numbers of people, but only if the prices are affordable. And I think the problem with hepatitis C is at the moment, if you look at the number of people in some countries and the cost of the treatment being asked for by the pharma companies, it's just way too high, and it would just be impossible to treat everybody with hep C in some countries at the current prices. So we need to have new approaches to funding mass treatment programs, either or you can treat pricing deals where you have unlimited treatments for a fixed price, or lower fixed prices, at least under 4,000 euros per cure for hepatitis C in high-income countries, and much lower prices in middle and low-income countries. You just need to remember most of these drugs are fundamentally extremely cheap to produce. So pharmaceutical companies can make a large profit from selling to large numbers of people at lower unit prices. What they're doing at the moment is treating a very small number of people for a very high price, but they could reverse that and still make a lot of money. Next slide. Now, if pharmaceutical companies just refuse to make these deals, we need backup mechanisms to ensure access. So compulsory licensing, where a country simply says the prices are unacceptable and they start importing the drugs en masse from these generic companies in India or Bangladesh. The buyers clubs are showing that people can be cured with these generics. In our experience, we've seen almost no counterfeits. The fakes are just not an issue. We're getting good quality supply. We can monitor people very early on to see whether the drugs are working. You know within 2 weeks whether somebody's taking good quality drug, because the viral load comes down so quickly. And then finally, if the companies really refuse to work alongside us, you need to think about how much money these companies are making. Gilead so far has sold $40 billion US worth of their hepatitis C drugs. 40 billion. If you just looked at the tax they've avoided by putting their intellectual property in Ireland, that's $10 billion alone. That's enough money to treat everybody with hepatitis C worldwide. So we've got the solution here. It's just about how we actually do it. Thanks very much.
Thank you. And again, another very important message right there. And I'm very wary of time. I have a question here. Clarification about Canada. People can carry in the generics on them but cannot courier them. Is that right, Giten? Sorry, Giten, can you just clarify importation for Canada?
Yes, legally it's not. It's not allowed to be couriered. That's correct.
All right, thank you, Giten. And what I wanted to say is just concluding from what Dr. Andrew Hill was saying, one of the things, and it was mentioned by Erika, was mentioned by Giten, we are exploring the generics role here, and again, it's unquestionable what it's been doing in terms of reducing the prices. But when it comes to the buyers clubs, for instance, fantastic option, but it's not, even though it's more affordable for a lot of patients, it's still not a reality. So we really need to start looking at public health approaches to making sure that the general population out there with hepatitis is accessing those drugs. And also there will be a need for a confluence, I think, of strategies and approaches if we are to deliver elimination. So just buyers clubs alone and what Giten was saying, just personal importation alone will not deliver elimination. We need to be treating masses of people. We have 80 million people out there with hepatitis C, and we have a cure. So I guess my message, at least on behalf of the World Hepatitis Alliance, is that we're very much pro-access and looking at everything that can be done, generics, the optimized procurement, so governments and companies really access information. And on that, just so viewers that might be interested in this, but WHO launched a hepatitis C access report just last week with information on different prices for different countries as well, which you can use in your country to help those negotiations. And one last question before I wrap up, if that's okay. It's around the perhaps differences in prices. There were some prices mentioned at Giten's presentation, some mentioned at with Dr. Andrew Hill's presentation, and I noticed that the WHO report has also different prices. And I just guess, is this because things are happening so fast that it's difficult to track those price reductions? Anyone, any panelist?
Yes. So it's the prices are dropping so fast. If you look at the price that Andrew had shared, this was made in Durban. This was in the Durban conference, an international AIDS conference. And if that's after that, the price has been dropping, and as we speak, even it's even further getting dropped. So, and then there is I will get, or someone else will get in a different price, whereas someone else will also get in a different price. So there would be no consistent pricing, as in this is the fixed price for 12 weeks of soft lead or soft diet. That's not going to be there. But the basic point is that the price drop has been so dramatic, and there is so much of competition among the Indian generic suppliers. There are like 15 suppliers altogether trying to sell this medication. So that competition itself drives the price drop to a large extent. So it's going to, it has been dropping from the time, as you saw in my slide. It will continue to drop. And velpatasvir will come out in the next 1 or 2 months, and then we're going to even see more drop.
Thank you. And I promised it was the last question, but I just got one last one, and it's a good one as well. So may as well just throw it out there, which is, can a doctor get in trouble for monitoring a patient using the generic drugs that they procured for themselves? Anyone have an answer to that question? I think we have doctors listening in.
Oh, sorry.
Go ahead.
Okay.
All right. So there was all right. You go ahead, Peter. It's fine.
Okay. So I mean, as far as I know, there are a lot of physicians in Europe who are actually monitoring. In Asia, anywhere in the US and Canada, who are actually, they don't get the medication by themselves, but they say that, okay, you get the medicine, and then I will monitor you. So we have physicians, GPs, ID physicians, hepatologists, gastro doctors, who are monitoring the patients on generics. So, and as for me, I have not come across anyone who have been fined or have been prosecuted or have been asked by anybody to justify why they're monitoring a patient who needs that treatment.
Dr. Underhill, anything to add to that?
Yeah, there was a legal review of this situation at St Mary's Hospital in London, and the conclusion was if somebody comes in with their own medicine that they bought themselves, the monitoring of it is absolutely fine. It's not the doctor that's actually made that prescription. The doctor is just aware that somebody's taking this medicine and they're allowed to monitor them. And so it's permitted in the major teaching hospitals in London.
Perfect. Thank you so much. And I'm again wary of time. So any last words before I conclude? Anyone? Any last words or remarks? No. All right. Well, thank you so much, everybody, for joining in. And thank you to all of our lovely panelists for sharing their expertise. And as I mentioned, we're going to be posting this recording online with a series of links to the documents and the tools that we presented here. So thank you, everybody, for attending this.
Thank you.